Okay, let's unpack this today. We're doing a deep dive into something pretty specific, medical care right after endovascular aneurysm repair, EVAR.
That's right. It's a big procedure, and what happens immediately after is crucial. The protocols are incredibly detailed.
And we've got some interesting source material for this, excerpts from a protocol. Is it Dr. Gregory Weir?
Yes, Dr. Weir, a vascular surgeon, his protocol really maps out the immediate post-op care step by step.
So our goal here is basically to pull out the key instructions, the main monitoring points from this protocol.
Yeah, to help you understand just how focused the care needs to be in those first, critical hours and days.
Right. So picture this. Someone's just had this repair. What's the absolute first thing, the top priority in this protocol? It seems to jump right into blood pressure.
Oh, absolute critical.
Yeah.
Straight away. The protocol sets a really tight target for mean arterial pressure, the MAP.
MAP, right. And that target is what, between 70 and 100?
Ideally, yes.
Yeah.
70 to 100 mmHg. Keep it right in that zone.
And it's not just keep it there. It actually says how to react if it goes outside that. Like, what if it creeps up too high, over 100?
Then the instruction is clear. Titrate nitrosine. That's a drug to, well, relax the blood vessels, basically. Bring the pressure down carefully.
Okay, nitrosine for high pressure. What about the other way? If the MAP drops too low, say below 70.
Well, then it gets a bit more nuanced. It depends on another reading, the CVP.
CVP, Central Venous Pressure.
Right.
That gives you an idea about fluid volume.
Exactly. It tells you about the pressure of blood returning to the heart, which relates to how much fluid is in the system. So the protocol branches here.
Okay, so walk me through that. MAP is low, under 70. What's scenario 1?
Scenario 1, MAP is low, and the CVP is also low, let's say below 10 centimeter H2O.
Mm-hmm.
That suggests, maybe not enough fluid volume.
Okay, low MAP, low CVP, needs fluid.
Precisely. So the instruction is give a Ringer's bolus. Ringer's lactate, it's an IV fluid, 250 milliliters per hour.
Got it. Bolus ringers. But what if the MAP is low, still below 70, but the CVP is actually high, say over 10?
Right. Low pressure. But the fluid indicator, CVP, is high. So adding more fluid isn't the answer there. It might even be harmful.
So what then?
Then the protocol says use noradrenaline titration. Noradrenaline constricts blood vessels, raises the pressure, but without adding more volume.
Wow, okay. That's really specific. Tailoring the intervention based on both MAP and CVP, it's quite sophisticated.
It has to be. These are critical moments.
What else is being monitored constantly besides pressure?
Well, oxygen saturation, obviously, often needs an O2 mask initially, and things like checking limb circulation, elevating legs if they're swelling, or edema. Also confirming the CVP line placement with a chest X-ray, that's standard, and keeping an eye on the Hematocrit, the HTT.
HTT, the red blood cell measure, needs to stay above 30%.
Yeah, above 30% is the minimum specified.
And labs. I saw there's a specific schedule for blood tests.
Yeah, very structured. Day 0, so immediately after the procedure, they check HTT again, and TROPT.
TROPT, that's the heart muscle stress marker.
Exactly. Troponin T shows if the heart's been under strain.
And then day 1, more tests.
A wider panel on day 1, yeah. UKE, that's urea, electrolytes, kidney function. FBC, the full blood count, CRP for inflammation, and also myoglobin, which can indicate muscle damage, and another TROPT check. It gives a really full picture of how the body is responding.
So tons of monitoring. What about just like basic patient stuff? Eating, moving.
Actually, diet comes back pretty quick. The protocol often allows eating and drinking right away on day 0.
That seems fast. And movement, getting out of bed.
Day 0 is strict bed rest.
Yeah.
No getting up. But then day 1, it shifts. Mobilization is tolerated.
Okay, strict rest, then moving the next day. But there was one specific thing about position that jumped out at me.
Yes. You mean the not allowed to sit upright instruction.
Exactly. Not limit sitting, not be careful sitting, just flat out not allowed. Why so strict about that specific position?
It really points to how delicate things are at the repair site, usually in the aorta, often accessed via the groin. Sitting fully upright, bending sharply at the hips, that can significantly increase pressure in the abdomen and groin. It puts stress on the arteries where they made the access points, potentially on the graft itself.
So it's about preventing strain, bleeding complications at the site.
Absolutely. It's a crucial detail to prevent undoing the repair or causing new problems.
Wow. Okay, so pulling this all together, we've got this incredibly detailed post-EVAR protocol, precise blood pressure management, MAP targets, CVP guiding whether to use ringers or noradrenaline, maybe nitrosine if it's high.
Right. Plus monitoring oxygen, HCT levels,
Yeah.
and that specific lab schedule, TROPT, UKE, FBC, CRP, myoglobin on particular days.
And then managing activity, strict bed rest initially, then careful mobilization, and that very specific critical rule. Absolutely no sitting upright.
It just shows you the layers involved in postoperative care. Every single instruction, every parameter is there for a specific reason to guide recovery safely after something as complex as EVAR.
It really makes you appreciate the precision and maybe something for you, the listener, to think about. How can one seemingly small instruction, buried in a complex protocol, like not allowed to sit upright, actually be so incredibly vital for a patient's entire recovery trajectory?